Hello, everyone. Okay, thank you, Dean Hamm. Hi, my name is Holly Golden, and I'm the Associate Vice President for Advancement and Executive Director of Development for the School of Medicine at Tulane University. We are thrilled to host tonight's virtual event and share the stellar work of our faculty. COVID-19 has certainly changed our world in many, many ways. During the presentations, you'll have an opportunity to share your questions using the chat function. While we may not be able to cover all of your questions during the webinar, we will do our best to follow up on them after the event. For those who submitted questions with your registration, you gave us an idea of what you wanted to hear, and they have been shared with our presenters this evening. It now gives me great pleasure to introduce our Senior Vice President and Dean, and the James R. Doty Distinguished Professor and Chair, Lee Hamm III, MD, FACP. Dean Hamm has been an extraordinary leader during this time of crisis, and we're very, very fortunate to have him here at Tulane. Dean Hamm has been a teacher and administrator at Tulane University since 1992 and became Dean of the Medical School in 2013. He has an outstanding reputation as a medical researcher, educator, and who was a hero when, as chairman of the Department of Medicine during Hurricane Katrina, he helped coordinate the evacuation of 180 patients from the Tulane University Hospital. Dr. Hamm has won numerous honors and awards, including a Merit Award from the NIH, and an American Heart Association Established Investigator Award, the Donald Selden Award of the National Kidney Foundation, and the Founders Medal from the Southern Society of Clinical Investigation. He's an elected fellow of the American College of Physicians and the American Heart Association. He was elected to membership in the American Society of Clinical Investigation and the Association of American Physicians. Dr. Hamm was selected as last year's recipient of the prestigious Spirit of Charity Award by the Spirit of Charity Foundation, honoring his contribution to medicine in New Orleans. Under Dean Hamm's guidance, our medical school has become even more selective, receiving more than 13,000 applications each year for 191 seats. The school is committed to diversity, and that commitment is reflected in the number of students from underrepresented minorities and first-generation students. I now turn the program over to Dean Hamm.
Thank you very much, Holly, for that generous introduction. I'm really glad to be with you tonight. You're going to hear some great information. You know, COVID has been something that has shaken the world and challenged everyone. But I've got to say that Tulane University and our faculty have made us very proud, and no one has made me more proud than our frontline clinicians taking care of patients and our research faculty. And among those, you're going to hear from three real stars tonight in doing that. So let me tell you about who's going to join us. First, Dr. David Mushatt. David is Associate Professor of Medicine and the Section Chief of Infectious Disease. He got his MD at Harvard, did his residency training at the Brigham and Women's Hospital in Boston, and then infectious disease fellowship at Tulane. Also earned an MPH at Tulane during the same time. He's been the principal investigator of the Louisiana Community AIDS Research Program, the Tulane Clinical Trials Program, that was formerly part of the CPCRA and now part of Insight, an NIH-funded international HIV research group that focuses on strategies in HIV treatment at the community level. His main research interest has been in HIV clinical trials, but he's also had interest in a variety of infectious disease topics: fungal infection, mycobacterial infections, orthopedic infections. The second person is Dahlene Fusco, MD, PhD. who joined Tulane only a couple of years ago. Dahlene got her MD from Albert Einstein in New York and her PhD in structural biology from Albert Einstein as well, and then training residency at the Mass General, followed by infectious disease fellowship at Cornell in New York. She runs a lab that is primarily interested in the interferon antiviral response to distal to viral subversion points using both in vitro and in vivo models, primarily for dengue and Zika viral infections in the past. She will use those studies for preclinical host targets for broad-acting antiviral design. I must say that too, Dahlene has been probably the lead clinical investigator on many clinical trials going on with the COVID infection, as the other ID colleagues have been as well. But John Schieffelin is our third star tonight, associate professor of both medicine and pediatrics in sections of both pediatric and adult infectious disease. He's a Tulane School of Medicine graduate, did a combined internal medicine and pediatric residency here at Tulane, and then adult and pediatric infectious disease training at both LSU and Tulane, and then joined the faculty of both medicine and pediatrics, where he both practices and does investigation. Recently promoted to associate professor. His research focuses on the natural history, clinical care, and immune response to viral hemorrhagic fevers. His NIH-funded research program focuses on Lassa fever and Ebola virus disease, as well as capacity building and training in West Africa. He also serves as a co-investigator on studies on the epidemiology and immune response to the SARS-CoV-2 virus. So you can see that all of these investigators have been involved in studies of viral infections, and when COVID hit, have really been able to pivot to focus a tremendous number of ongoing studies on COVID, while they simultaneously do a great deal of clinical duties. At this point, I'm going to turn the program over to Dr. Mushatt, who will give us a broad overview of COVID-19 and Tulane's response.
Thank you, Dean Hamm, and good evening and welcome to my fellow WAVE alumni. Thank you so much for tuning in this evening. I only have 15 minutes, so hang on to your seats. This is going to be a quick ride, but I'm going to focus on the clinical update, and then Dahlene Fusco will talk about research that we're doing, and John Schieffelin will talk about the pediatric aspects. So this is the Johns Hopkins COVID website. It's a wonderful website that coordinates a lot of the data, and this is a screenshot from 2 days ago, which shows that worldwide there's nearly 14 million confirmed cases of COVID, over 500,000 deaths. In the US, we have probably by today over 3.5 million cases, with probably over 137,000 deaths. So this is probably the best place to get this information overall on a daily basis. Turning to Louisiana, this is the Louisiana Department of Health website. They have a very nice map that they show every day, and you can see that as of yesterday, we had about 84,000 cases reported, 3,300 deaths. I'm pleased to see that as of yesterday, over 1 million people in the state of 4.6 million people have been tested. That's not too bad. But our numbers are starting to go up. As you can see, all of the parishes, as we call them down here, or counties elsewhere, are in the red. So every parish is seeing an increase in cases. We're not as bad as rural Louisiana, places like Rapides, Baton Rouge, St. Charles. Lake Charles and other more rural areas have been seeing an upswing for a while, but we're starting to pick up a bit in New Orleans. So this is the experience at our local hospitals between the first case on March the 9th and May 12th. And this includes the VA, the Veterans Affairs, the University Medical Center of New Orleans, and TMC. And you can see that all told, over that 2-month period, we accumulated over 1,000 inpatients that we and LSU were involved in taking care of, because, of course, at UMC we do share clinical duties. You can see that the maximum number of patients one day at VA was 72, at Tulane it was 66, and UMC was 185. That was a very hectic and chaotic time. Thankfully, things settled down, but I worry now that things are starting to ramp up again. I certainly hope that we don't have a surge of this magnitude, but time will tell. So one of the most controversial aspects of COVID-19 that I'm going to start with, of course, is the whole ideas of how this disease is transmitted. There's been a lot of back and forth. There was the article or letter to the WHO last week signed by hundreds of scientists asking that they take the aerosol transmission theory more seriously. So basically what it comes down to is probably much, if not most, of transmission occurs through droplets. And this is a matter of semantics, but they are important. Droplets are the larger, greater than 5 micron diameter particles that come out when we cough, sing, sneeze, etc. And they generally fall to the ground within 6 feet. So we think of most of the transmissions through this route. Some, of course, will occur through fomites, through surfaces such as bed rails. It's probably not the major route of transmission, but it probably does play a part. The role of aerosols is very controversial, but there's an excellent article by Mike Klompus in the JAMA earlier this week that summarizes for and against aerosol transmission. These are the very small, less than 5 micron diameter particles. Chad Roy and his colleagues at the Tulane Primate Center, of course, published a very important article demonstrating that the aerosol droplet nuclei can remain suspended for over 16 hours with virus, and they can travel up to 27 feet. So that certainly sounds very concerning. On the other hand, that was a laboratory-based study, of course. It may or may not reflect the real world, where there are air currents outdoors, there's ultraviolet light, many other factors that play a role. The article in JAMA, their thesis was that aerosols probably don't play a major role, because while it seems possible based on laboratory findings, the epidemiologic data does not support a major role for aerosols. Nevertheless, the CDC does now recommend that we wear face shields or eye protection when we are seeing patients, particularly for over 15 minutes. So just to recap, the incubation period remains at 2 to 14 days, which makes this disease very challenging because it can be a very, very long incubation period. The median is still about 5 or 6 days. The symptoms classically are fever and or cough or shortness of breath. But many patients have other symptoms such as flu-like symptoms like myalgia, sore throat, headache. Abdominal pain, nausea, vomiting, diarrhea can be the sole manifestations in a minority of patients. And this very interesting finding of loss or decrease in taste and smell, which occurs in a minority of patients, but when that is observed, it's highly suspicious for COVID-19. So this shows you some clues for the diagnosis. So if you see somebody who comes in with unexplained hypoxemia, and particularly if they have lymphopenia and or transaminitis and a normal procalcitonin, you should be thinking very strongly about the possibility of COVID-19. Interestingly, many, if not most of these patients do have some degree of elevated acute phase reactants. They often have very high CRP, elevated LDH, ferritin may be high, D-dimer, and other markers of inflammation. Radiologically, these patients have very classic patterns of these peripheral multifocal opacities. In this CT scan here, you see one of the classic ground glass opacities. Early in the epidemic, most patients were getting CTs. That's not the case now, because we do not want to unnecessarily expose our staff, our radiology technicians, et cetera, to these patients, chest x-ray generally will suffice. But once you've seen, 5 or 10 of these x-rays and CTs, it becomes a very recognizable pattern. This is some data from BMJ from the UK that shows in a forest plot, the major risk factors for mortality, predictors of mortality. You can see, I think everybody knows this, as age goes up, the risk of mortality goes up, the hazard ratio increases substantially. Female sex is actually protective. It may have something to do with ACE2 receptors, but it may be hormonal. There may be other genetic and other factors. Clearly, cardiac disease, pulmonary disease, kidney disease, diabetes, obesity, underlying neurologic disorders, including dementia, malignancy, and underlying liver disease are all risk factors. I didn't even mention hypertension, which seems to be a prominent risk factor. I love this graph. This was published by JAMA over 2 months ago, and this summarizes the situation with serologic and molecular testing in this disease. And basically what you see here is that if this dashed line represents the onset of symptoms, PCR can start to turn positive before the onset of symptoms, as much as a week before, but probably more in the order of 2 to 3 days before. And then you start to see serology, IgM, IgG, and even IgA pick up. And that they usually start to occur somewhere around week 1 or 2, okay? So not in that first 6 to 7 days, but after 7 to 10 days, you'll start to see antibodies go up. And how long they stay up, the jury is still out on that. The PCR generally starts to go down around week 2 or 3, but we have seen patients remain PCR positive for 40 or 50 days. A very common question in the pre-meeting questions that came through was sensitivity and interpretation of serologic testing. The newer antibody tests are very sensitive, but it depends on stage. If you test somebody in the first 7 days, they're probably not very sensitive, maybe 50, 60%. But if you do antibody testing out at about 14 to 21 days, your sensitivity gets up around 95 to 100%. Specificity is getting better. The best tests now quote specificities of over 99%, which is what you need so that you don't get a lot of false positives. And the good news is it appears that the best tests generally don't seem to cross-react with other coronaviruses, although we'll get a better handle on that as more and more patients get tested. I would not rush out to get testing, however, because we still do not, and I repeat, we do not know if a positive antibody test guarantees protection against reinfection. And I will tell you that I heard today about at least one case locally of a reinfection 3 months after clearance of PCR positivity. This patient had natural infection, yet it appears they've gotten reinfected. So a positive antibody does not guarantee that you won't get infected again. So what are the complications of COVID? And this is what makes this disease so interesting and so challenging. Everybody's heard about adult respiratory distress syndrome. ARDS is not unusual in hospitalized ICU patients. Interestingly, some people get septic shock. The heart has ACE2 receptors, so we do see myocarditis or cardiac arrhythmias. The real hallmark of this disease is hypercoagulability, like we've almost never seen before. We see a high incidence of pulmonary emboli, DVT, and microthrombi on biopsy and autopsy. And so we've gotten a lot better about anticoagulating. Some patients get acute kidney injury requiring renal replacement therapy. Cytokine storm and HLH are definitely described. There seems to be more large vessel ischemic stroke and other neurologic syndromes such as encephalopathy. Dermatologic findings range from COVID toes, seen more in kids, to petechiae, and increasingly now there is being described this post-COVID syndrome in patients who are no longer have detectable virus, but have ongoing respiratory symptoms, fatigue, and even loss of taste and smell. Just a word about the cytokine storm. There's some debate about whether this is a real phenomenon or not. It's a little unclear. And part of the problem is that there is no consensus on how to define this. This is a particular monoclonal antibody that Tulane is now studying. It's an anti-GM-CSF for patients who meet these criteria. This is this particular study, its criteria. It just gives you a sense of what some scientists and experts consider to be cytokine storm, and that is a very high ferritin, a high CRP, a high D dimer and LDH. But I will tell you that if you look at all the different studies, there are widely disparate thresholds for how this is defined, and we need a lot more experience and data on this particular entity. This is an old surveillance pyramid that still has withstood the test of time, and it basically tells you that about 80% of cases of COVID we think are mild, and the remaining 20% are severe or critical. Roughly anywhere about 20 to 30%, sometimes 40% of inpatients do require ICU care. It really depends on where this is, the city, the country, the type of patients, the number of risk factors. But this is held up pretty well. And I think that everybody is hearing more and more about the race and ethnic disparities with this disease. And as you can see here that in this data from New York City, whether you look at cases per 100,000, hospitalizations, or deaths, unfortunately, African Americans lead the group in terms of these statistics. And it's a very, unfortunate and sad situation that really, sort of reveals the sort of, the ugly belly of American society in terms of access to care, social determinants of health, and other factors that put our minorities at risk.
Dr. Mushatt, just
yes.
real quick, I hate to interrupt. We have a lot of questions that are coming through.
Okay.
And just finish up in the next few minutes. We'll move on to our next panel.
Sounds good. And I will send these slides out for people who want to review. And this is a chart that shows you sort of how the disease is thought to play out. People with mild disease or who first come in generally have high viral load and probably respond better to antivirals at this point. But as they develop respiratory failure in the ARDS, it becomes more of an immune-mediated disease when immunomodulators probably play the biggest role. There are many drugs that are being looked at in immunomodulators, and the first one to receive emergency use authorization is Remdesivir. And what I show you here is that in the group that was on oxygen but not ventilated, they had the greatest benefit with a hazard hazard ratio of 1.47 and a significant confidence interval, and so there was a significant benefit. In the recovery trial from the UK, it was found that dexamethasone was beneficial, and here you see the data. The greatest benefit was in the ventilated patients with a 35% reduction in mortality, and in those just on oxygen, a 20% reduction in mortality using 6 milligrams of dexamethasone once a day. But we need more data on larger numbers of patients. This is one of our protocols that I've come up with recently, where if you have saturation less than 94%, you are evaluated for remdesivir plus or minus dexamethasone. We encourage prone ventilation, and aggressive anticoagulation. This is our protocol, and I want to get into the details, but Cindy Lessinger, the chief of Tulane Hem-Onc, is a world-renowned clotting expert, and she has come up with these along with, based on guidelines that will be updated as clinical trials come in. But we have a low threshold to go to therapeutic anticoagulation. Interestingly, post-COVID symptoms are being observed, and as you can see here, this is a study from Italy published recently in JAMA that shows that the most common symptom is fatigue, and then shortness of breath, joint pain, and chest pain. And the majority of patients had 1 to 3 symptoms. More to come on this. We're going to learn more about this as we start to study this, but unfortunately, this is not a rare finding. The experts at CIDRAP have projected the following models for the next 18 to 24 months. It does seem like we might be in a second wave here, whether it's going to be the same as the first or worse. A so-called fall peak is unclear at this time. But we certainly are expecting to have recurrent surges and peaks until we achieve herd immunity. If I leave you with one message, it's we need to flatten the curve. This is true early on. It's still true. The best way to get through this is to mitigate and reduce the number of cases on a daily basis so that the number of cases that are coming in for care are manageable below this line so that we have enough beds, enough drug, remdesivir, dexamethasone, other adjuvant treatments. We need to keep this manageable so that we can continue to manage it. The good news is that the Operation Warp Speed, the big vaccine project, is looking at least 5 promising vaccine candidates. Moderna is the one from Cambridge, Mass. It's being done with NIAID, and excitingly on Monday, the New England Journal published their results that basically in a nutshell show these results here where the mean geometric titers were higher than at baseline, and on average they were about 2 times the antibody titers seen with natural infection. This bodes well, but it is by no means a guarantee of efficacy. Down here you see that the neutralization antibody titers were also very promising, but again, we don't know for sure if these antibodies are the right antibodies to actually neutralize and prevent entry of the virus into our cells. There is always a possibility that cell-mediated immunity may play a role. And in a study that I just saw reviewed today, there is now some data on the T-cell response, and this is something that will need to be looked at in the vaccines. A study published earlier this week suggests that to extinguish the epidemic, we need a vaccine with at least 80% efficacy and 75% vaccine coverage. That's a somewhat daunting vaccine coverage, but it's doable. However, the good news is that even if the vaccine is only 40% effective, it could prevent almost 3 million patients from requiring a ventilator and at least 90 million hospital bed days. I've got some useful publications here that you may want to review. JAMA has an excellent website. This is my COVID survival kit. I particularly like the literature compiler here that weekly compiles the most important, meaningful literature. And with that, I'll encourage you to sign up for Tulane's wonderful Tulane COVID Daily Digest that summarizes 5 to 6 major studies that have been published in the literature. It's a fantastic job being done by our research team. And again, thanks to everybody who's been involved in the research, whether it's the patients and the staff. Roll wave. And with that, I will turn the podium over to my colleague, Dahlene Fusco.
Thank you, Dr. Mushatt. Dr. Fusco, if you'll unmute, you are ready to go.
Can you hear me?
Yes.
Hi, this is Dahlene Fusco. Thank you so much for the privilege of speaking tonight. Next slide, please. This is going to be a non-exhaustive review of the research going on at Tulane, and I'm honored to try to accomplish this, but I want to try to make sure I touch on everyone. The main point is that there is a lot going on, and it won't be possible to go in detail about everything. We'll talk about highlights of clinical trials and then a deeper dive on one of many studies that are going on. Next slide, please. So this is just the current list of clinical trials that are either recently enrolling or currently enrolling. Dave mentioned the anti-GM CSF trial. I just want to point out that we have a lot of trials going on. Before I say that, I want to point out that on a weekly basis, we are reviewing every trial that gets sent into us. There are dozens of trials coming in per week, and Dr. De La Fontaine has taken the initiative of organizing a scientific and clinical group that reviews every study that we hear about every week. And then if we hear about a good one, we fight to try to participate in it. And I see some questions rolling in about vaccines. I don't know of a current vaccine trial. We're trying to get some of the vaccine trials. These are the current and recent ones, and you'll notice there is a mix of investigator-initiated studies. There are double-blind, placebo-controlled randomized studies. There are studies that are not controlled but are investigator-initiated. There are studies that are enrolling only at a few sites, and then there are multinational trials that have over 100 sites. So there's a big mix, and we are trying to think very carefully about which ones are selected. I will put in a little bit of a plug for a study that is just about to open this week by Regeneron. Full disclosure, I'm the PI on this one, but I do want to point out this one right here, that it's a unique study where we're going to be attempting a double-blind, placebo-controlled, randomized trial for antibody infusion to see if giving direct antibodies could serve as a therapeutic. Hydroxychloroquine's in trial, estradiol, these two are closed. We do have remdesivir through EUA currently. So we can get people Remdesivir for the moment. We don't know how stable our supply is. And I will point out that we're being reviewed by Gilead for outpatient Remdesivir in both inhaled and injected form. So that's more to follow on that. We have BTK inhibitors, convalescent plasma, desulfated heparin, which is a very, a study that was really conceived of by people at Tulane, and the IL-22 FC, being run by Dr. Coles and Dr. Bojanowski. Dr. Coles also has a large research program, and our anti-GM-CSF led by Denson, who's in our ICU. We also have some preventives. Hydroxychloroquine is ongoing, and we're about to open monoclonal antibodies as a household exposure tool. So people who are exposed in the household could then potentially get subcutaneous antibody infusion, and then we follow to see if they are protected. So this, again, is not fully representative of everything, but this is a smattering of what we're trying for the moment at Tulane, and we're partnering with UMC for a lot of these studies. So next slide, please. I want to point out that clinical trials don't just happen. We are incredibly lucky that the leadership here has anticipated the need for a really big clinical translational unit, and we had a nice, healthy, large staff going into this, and the staff is growing. They're led by Roberta McDuffie, and these guys have been working 24/7 since COVID rolled into town. And I think we're all grateful for them, but they need a lot of support because we have a lot more studies coming. So, next slide, please. So next I want to transition into one of the many studies that are going on right now. This one happens to be our observational study that we have nicknamed ClinSeq-Seer, looking at the clinical virus sequence and serological, so antibody response to COVID. It's funded by the CDC, and the CDC has been incredibly engaged in trying to figure out what's going on in Louisiana. So we've actually, we were supposed to start on July 1st. We actually started our calls with them a week before that, and we talk to them every week about what is going on in New Orleans in terms of COVID. Next slide, please. So the objective of this project is to provide a detailed description of clinical virus and immune, both antibody and cytokine, response to COVID-19 in Louisiana, particularly trying to tease out whether there are race differences. And at this point, we're actually looking even among our large African-American cohort, if there are differences among African-Americans for inflammatory response. Next slide, please. So you might be aware that St. John the Baptist Parish, which is unfortunately known as part of the cancer belt in Louisiana, has also been found to have the highest per capita coronavirus mortality rate in the nation intermittently since this epidemic started. And so we are trying to figure out whether there's something going on in parts of Louisiana that's contributing to higher mortality. Next slide, please. And so the results expected for this grant are some form of an explanation for why we've got high mortality. And again, that mortality is kind of moving around where it's the highest in the country, and also a description of where virus is shedding. Next slide, please. So, and so what we're doing is collecting all sorts of secretions from people to assess when and where viral RNA shedding is occurring using both qPCR and CRISPR. I know there were some questions about CRISPR. So Tony Hu and Bo Ning are leading an enormous amount of work looking at developing novel CRISPR-based technology. So this is kind of like a detecting mini fragments of the virus with high sensitivity using a quick readout, such as a cell phone. And then to figure out which portion of that, how much of that virus is actually alive, we're working with Jay Rappaport and Brandon Bedingfield, who are at the Non-Human Primate Center, which is just a national treasure, I think a lot of people are aware of. But just like Chad Roy, Jay and Brandon have been doing a massive amount of work on trying to figure out with the primate models where there's virus that's shed that's live, and we're going to accompany that with human samples. And Bob Gary has also been helping us a lot with the shedding assays. Next slide, please. And we're looking also at the sequences with that. We're also looking at the immune response. Just as Dave pointed out, we don't know the immune correlative protection. It's really important to drive home the point that he made that we heard this morning of someone who has been infected twice. We don't know if an antibody if a particular antibody means you're protected. I can tell you from our preliminary data that some people have a very high antibody response and then die. And so we cannot say that a strong antibody response globally means protection. We're working with James Robinson and Bob Gary to look at anti-spike and anti-nuclear protein antibodies. So again, this is the immune response against the virus, and trying to figure out whether particular parts of that immune response are helpful, in which case they might tell us how to make therapeutic antibodies or basically infusions of that good part of the immune response. And that might also tell us what should we target when we try to make vaccines or select the vaccine trials that we want to bring here. Next slide, please. So I just want to point out that we have a really big team. One person from California, everyone else here is from Tulane, helping with recruitment and a clinical study, statistical analyses, immune response assays, including those antibodies and then the chemicals the body makes called cytokines, and then the virus assays. And we're really grateful for this huge team. Next slide, please. We've been recruiting our subjects. We actually had our first consent on March 21st, right when those first cases came in. We started in our lab tracking what was going on in China in early January, started writing mid-January, and we're ready to consent and nervous by March. We've got 118 subjects enrolled so far. Next slide, please. And among our cohort, there's a 12.5% mortality, which is what you would expect from an inpatient hospital cohort, average age 60. Illness onset for our first part of our cohort was nice and early, so we're capturing samples that were right at the beginning of the epidemic, and we have ongoing recruitment. Next slide, please. One thing in our little cohort that we've noticed is that higher age is associated with worse clinical severity. Next slide, please. Something really positive is that over time, we very quickly were able to see a decrease in the turnaround time for the tests. I can't overemphasize how much work people put in. Ditian, Xiaoming Yin in pathology, and Bob Gary's team with Allison Smither working around the clock to get this up and going. And Gail Froba and Jack in the lab, all these people were just working constantly to try to get all of these tests up and going, and we've kind of settled in with 2 different tests that are working really well. Next slide, please. And another really positive thing is people very early on caught on that they should present earlier in their symptomatic course so that we could get them taken care of, and the diagnosis, the date of symptom onset versus the time to first swab dropped nice and quickly. So that was great. Next slide, please. And then this is just a little bit of sequence data coming from Christian Anderson's group in California with a collaboration through Bob Gary, showing that basically the New Orleans sequences, which are in orange, are kind of distributed in a way that the whole rest of the countries are, and that Mardi Gras did not appear to introduce a bunch of very exotic sequences, but more to come on this soon. They're analyzing more data as we speak. Next slide, please. So the main deliverable that we're trying to provide is a comprehensive description of virus shedding and antibody production per body site over time. We're trying to make sure that if your nasal swab is negative, you're not spitting out a bunch of COVID as you speak. You know, it's not in your saliva, even though your nasal swab is clear, or not in your urine with a clear nasal swab. We feel that that'll help us figure out how to better control the spread. And at the same time, we think those antibody studies looking at how the body immune response is built up will teach us about vaccines and potential therapeutics. Next slide, please. And so again, I just wanted to acknowledge the whole team that's been working on this project. It's a big team and growing. And next slide, please. I wanted to thank the CDC for supporting this work, and the Tulane leadership, especially Dr. Hamm, Dr. Piedmonte, who I should mention is studying our youngest patients, newborns and pregnant women as well. Dr. De La Fontaine, Dr. Wood, Vivian and Dave, and the leadership from HCA and UMC, the CTU, the IRB, and particularly our patients and their families who've been participating. Thank you.
Thank you, Dr. Fusco. Wonderful, wonderful information. We appreciate your time so much. And now we would like to turn the floor over to Dr. John Schieffelin.
Great, thank you very much. Thank you, Dr. Mushatt and Dr. Fusco. So we're gonna change gears a little bit. I'm gonna keep my pediatric hat on, which I've had on for most of this outbreak since early March. For those of you who don't know, after many years away from Children's Hospital, Tulane Pediatrics went back to Children's Hospital of New Orleans about a year ago. And we have been very, very busy there and active in infection control and antibiotic stewardship and all the good things that make a pediatric hospital function, including the response to COVID. So if you could give me the next slide. So I want to start out with a little, the way things were back in April. You can see on this slide, the blue bars are the number of cases in Louisiana by age, and the yellow columns are deaths. And you can see by this that it was tilted a little bit towards the older age group. So older adults seemed to be more affected by this outbreak. Now, granted, back in April, we were short on supplies, so we were a little more conservative, especially at Children's in terms of who we were testing. So for example, if parents brought their children in and they said that one or both of the parents had tested positive and their child was sick and they wanted to get their child tested, we usually just said, your child has COVID, don't worry about it. There's no point in testing, go home. We need to save our swabs and testing kits for other people. So we probably were underreporting, but if you go to the next slide, this is where we were yesterday, and you can see that there's actually been quite a big shift in who is being diagnosed with COVID in Louisiana. So we still have a significant number of adults being diagnosed, but the number of children has jumped up quite a bit, and the number of young adults has really increased. And so for those of you who have fond memories of living in New Orleans or still do, unfortunately, a lot of those memories probably involve going to bars before you were 21 or right after, and or big house parties. And this is where we're really getting hurt right now, especially in the New Orleans area. Next slide. And just as I think both Dr. Mushatt and Dr. Fusco mentioned, the bad news on this slide is that the older you are, the higher your risk of mortality. But as a pediatrician, we find this rather comforting because the patients that we take care of generally have a very low risk of dying. And in fact, at Children's, I think we've diagnosed now between 90 and 100 patients. We've had about maybe a dozen that needed to be hospitalized. And fortunately, we haven't had any deaths yet. Next slide, please. So what's going on in the rest of the country? And things have certainly changed over time. So you can see here in this slide, this is data mainly, this is data from the CDC, mainly from cases in the Northeast. So New York, New Jersey, Connecticut is the bulk of this data. And as I mentioned just before, you can see that we weren't seeing a whole lot of kids early on, but that has increased steadily. And that's reflected in the increasing height of the blue columns. Those represent new cases by day. And next slide, please. This is also from that same data from the CDC. It's a little old, but I think it really represents nicely what we're seeing in children even now. And what you can see in the figure on the right-hand side is that the younger you are, the less likely you are to be hospitalized. I'm sorry, the older kids are less likely to be hospitalized and even less likely to be in the ICU. We tend to hospitalize more frequently children that are under a year old. To be completely honest with you, I think a lot of that practice is due quite a bit to just general nervousness about infants, because most of those just stay one night and then we send them home. The ones that we are seeing here seem to be doing quite well. Next slide. And this slide also from that same article, again, nothing has really changed since April when this article came out, but it gives you an idea of what symptoms children have compared to adults. So they're quite likely to have fever and cough and but not as likely as adults to have shortness of breath. They really have significantly fewer symptoms than our adult patients. And there are a lot of theories as to why that may be. There are a lot of viruses that children get all the time that they just don't respond to very strongly. Their immune system is able to get rid of it, but it just doesn't make them feel very sick, and they rebound really nicely. There are some other theories too, that perhaps they are less likely to have experienced other coronaviruses, and maybe for adults who have seen other coronaviruses in the past, perhaps our immune system really is having trouble distinguishing the two and gets a little overexcited. Next slide, please. But those are all theories that we're hopefully going to test too. Oh, if you could go back one slide. I think the important message here on this slide is that quite a number of children are asymptomatic. So there's some data that just came out recently showing that about 20% of children who get infected have absolutely no symptoms at all. This is actually a significant number, but it's actually less than what other people have predicted based on other similar viruses that infect children every winter. So there are a lot of children out there that probably get infected and don't have symptoms, but it's, and there is still some debate about whether or not these children may be little super spreaders running around, spreading virus everywhere. But if you go to the next slide, please. So this data just came out. It's from Europe, but it's probably one of the larger pediatric studies that was done. This is data from across Europe. These are all patients who are connected with the big hospital systems. So this data is a little biased towards kids who were sicker and may not represent all children. But there are a couple of really interesting things in this data. First of all, boys and girls are just as likely to get sick, which is a little different from the data Dr. Mushatt said. Again, 62% of these children had to be hospitalized, which means that this this patient population is a little biased towards sicker patients. And quite a number of them, 25%, had some other pre-existing medical condition, including cancer was one of the biggest components of those pre-existing conditions. And those kids with pre-existing conditions were twice as likely to end up in the ICU. But I think perhaps one of the most interesting things about this data is when they looked closely at where children got infected, well over 50% of these children came from households where an adult member of the household had gotten sick days to a week prior to the child becoming sick, which suggests that for most of these children, it was the adult that brought it into the household and infected other household members, not the children who are spreading it around to each other and introducing it to their household. So that's one bit of data, not the complete story, but one bit of data that perhaps these kids aren't the super spreaders that we think they are. Next slide, please. So one other thing that's come up a lot is, what do we do about vertical transmission? So what's the risk of to babies who are born to mothers that are COVID positive? We don't have a lot of data yet, but it turns out there really doesn't seem to be much risk at all. And these little newborn babies actually do quite well. We do still encourage moms and babies to at least separate while the moms are symptomatic. Always a tough family situation, but that is what our guidelines are right now. Next slide, please. So one of the big hot topics right now is this multi-system inflammatory syndrome in children. For those of you who are not familiar with Kawasaki syndrome, Kawasaki disease is something that we see quite commonly in children. We don't really know what causes it, but it is this inflammatory syndrome where children come, they usually have fever. Well, they have to have fever and a rash, very red eyes and other symptoms. Just like some of this MIS-C, we treat it with steroids and something called IVIG. The multi-system inflammatory syndrome, though, is a little bit different. Some people have referred to it as Kawasaki disease because the kids develop shock very quickly and often end up in the ICU. And next slide, please. So this slide is just some data, and I apologize for the formatting issue there, comparing MIS-C to what are Kawasaki patients. The thing that's interesting about these children is that they tend to be older than kids with Kawasaki, and they are much more likely to have severe heart problems that require admission to the ICU. Next slide. So the next couple of slides, actually, if you go to the next slide, that's even better. What this shows, which I find a really interesting epidemiological phenomenon. So the previous slide was from Europe. These two slides, the one on the left is from just New York City. The one on the right is from hospitals all across the country, including data on several children with this multi-system inflammatory syndrome in children from a children's hospital that we took care of. And what it shows is that about 2 to 3 weeks into the COVID outbreak in any particular city, these children suddenly pop up in our hospitals. And this is something that our colleagues in New York, as well as Seattle and Atlanta, that we've been speaking to regularly, are also seeing. We had our peak about a month ago, where we had 5 or 6 of these kids in pretty rapid succession come to Children's Hospital, and now they seem to be declining again. Hopefully it'll stay that way. Next slide. So the last thing I wanted to bring up, and we're running a little short of time, is, because I know there are several questions about this, are when should children return to school? And this unfortunately has become a bit of a hot politicized topic. Next slide, please. But really, from a pediatrician standpoint, and the American Academy of Pediatrics also agrees that we need to do what we can to get kids back in school, because that is where kids learn best. And next slide, please. But we want to do it obviously in a very safe way. And some of my colleagues at Children's are working at the state level to help the state boards of education figure out what are the best ways to do this. Not only in Louisiana, but schools across the country are really trying to come up with innovative ways to get kids back in the classroom safely, where they are protected, their teachers are safe, and also the people that they go home to at night stay safe as well. And this really what this means is that school is going to look very different for in the fall, and probably for the next, I hate to say, several years, while we keep on dealing with this pandemic. Next slide, please. And I'm going to stop right there because we're running so short of time, but thank you all, and keep washing your hands, and please wear a mask.
Thank you all, presenters. Dr. Schieffelin, thank you for that. That's a great piece of information that isn't always made available to folks. We very much appreciate everybody's time here. We've got time for maybe one question, but I do want to remind you all that if you asked a question and it was not answered, we will follow up with you and you'll get your information via email. So one question that came from Emmett Chapatal: what is the status of Tulane's research on the development of a vaccine or using artificial intelligence to attack the virus molecules to help find a cure?
Dahlene, do you want to field that? I know that the Primate Center is working on a vaccine, but I don't know the details.
So, hi. So I think that we can say that the study that we're about to start with Regeneron was fueled by AI. The two antibodies that were selected, one was using a mouse platform, the other was using a human platform, and the antibody platform is being tested in parallel at our Primate Center. So, like I said, we've been screening really carefully for the studies that we're fighting for, and this was one of the top ones. So I think AI, we can say that AI was involved in the original platform generating the selection of these antibodies. These are not a vaccine, these are delivering the product, the immune product, as a therapeutic and then also as a prophylactic. And then the vaccine trials will be the next step, but we hope to be running both in parallel.
Great, thank you very much for that. I am going to be cognizant of everyone's time. Thank you again, all of you that joined us. We appreciate your interest in the COVID and in this way supporting Tulane University School of Medicine. I want to thank all of our presenters, Dr. Schieffelin, Dr. Mushatt, Dr. Fusco, and also Dr. Dean Hamm for joining us today. I do want to let you know there have been several questions about availability of slides. We will send slides out. We have your email because it was used when you registered for this webinar. So you will be getting slides. And again, if you didn't get your question answered, you will get something from email. So thank you all so very, very much. I hope you enjoy the rest of your evening.